Well, hello there, everybody, and welcome to this panel launch on enabling health solutions for internally displaced persons. This panel and the research outputs and network that it launches are a joint venture co-convened by three specialised research institutions. Firstly, the UK Academy of Medical Sciences, represented here by Academy Fellow Dr. Gina Swartz, which brings a global medical research perspective. Secondly, the London School of Hygiene and Tropical Medicine, represented by Professor Bayard Roberts, contributes a focus on public health in humanitarian crises. And thirdly, the Internal Displacement Research Programme at the University of London, represented by me, Professor David Cantor, adds a specialism on internal displacement and protection. Our collaboration and the event today results from the realisation that health in internal displacement is a neglected global challenge. Over 45 million people currently live forcibly displaced by armed conflict within their own countries. Crucially, in many of these low and middle income countries, where the health system is already overwhelmed, such internally displaced persons, or IDPs, experience acute health needs, often more so even than other conflict-affected populations, including refugees. And the ongoing COVID-19 pandemic has only exacerbated their situation. In short, this means that if we wish to enable more equitable health outcomes globally, then IDP health must be a priority. Yet our understanding of IDP health remains fragmentary. Next slide, please. This brings us to the event today. Over the next hour, we'll be using this online space to launch three major outputs from an expert workshop that we jointly convened in February of this year, precisely to engage with this challenge of health and internal displacement. That work was given particular urgency by the need to feed a stronger focus on IDP health into the work of key policy platforms, including the new high-level panel on internal displacement, set up by the UN Secretary-General to reinvigorate and transform the global response to IDPs. Next slide, please. Coming back to our February workshop, which was held across 2 days online, this event brought together over 30 leading researchers in health from 15 countries, as well as representatives of the high-level panel and other policy actors. Together, we reflected on the current state of research on IDP health and its implications for enabling health solutions for IDPs. Many of those same experts are among the participants here today, and I'd like to say a really special thanks and welcome to all of you. Today's event, though, focuses on launching three key outputs from that workshop. Firstly, a one-page policy brief that summarises key research findings and policy implications, which has just been sent to the UN high-level panel. Secondly, a report of the broader expert discussions that took place at the research workshop. And finally, we launched today a global Health and Internal Displacement Network, HIDN or HIDN, which is open to new members. Both of the key output documents will be sent to all of you by email following the event, but to launch them now, our event today is comprised of four main parts. Firstly, we're going to present the new policy brief. Dr. Swartz will present its three main research findings on why IDP health is often so poor. Professor Roberts will present its four key takeaways on how health providers and policymakers can enable better IDP outcomes. Secondly, as part of our wider engagement with policy and operational actors on IDP health, we'll ask our four invited high-level speakers from those institutions to offer practical perspectives on the issues raised by the policy brief. As participants, we invite you all to put comments and questions in the chat box while the presentations are ongoing. Then, in the third part of the event, there'll be a short discussion session in which the panelists can respond to the main points raised there. So please don't be shy. Use the chat box from now on to start putting forward your questions. Finally, in the last 5 minutes, I'd like to share details of the Health and Internal Displacement Network that launches publicly today, including upcoming activities and how to join. Allow me to end with some standard Zoom housekeeping reminders. Please do keep your microphones on mute and your videos off, unless you're a presenter. We will be recording this session, and the podcast should be available next week on our websites. Let me also direct your attention again to the chat function on Zoom, where biographies for all the speakers will be posted shortly, and where you can start to input your questions and comments for the discussion session. We move next to launch the findings of the policy brief. We begin with Dr. Gina Swartz, representing the Academy of Medical Sciences. Over to you.
Thank you, Professor Cantor. If we could just advance onto the next slide, please. So we'd like to build on the research review and the discussions that we held at our successful international workshop. In doing so, I will present our three main research findings contained in the policy brief being launched today on why IDP health is often so poor. It is worth pointing out that our review of current research found the published evidence quite fragmentary. These findings thus reflect the research as it currently stands, acknowledging that there are specific deficiencies and gaps in the data. Please note that our workshop focused specifically on internal displacement driven by violence or conflict, rather than in the context of disasters or climate change. Next slide, please. The first key finding that we identified is that generally existing evidence shows that IDPs in conflict contexts tend to experience worse morbidity and mortality than other conflict-affected populations. They usually suffer significantly worse health outcomes compared with local residents, non-displaced populations, and indeed compared to refugees. They experience higher mortality, are at risk of infectious disease outbreaks, and suffer worse mental health consequences. This is not to create hierarchies of need or to suggest that refugees and other conflict-affected populations do not suffer. Rather, the point is to highlight that IDPs tend to suffer from particularly poor health outcomes. If you look at the next slide, this illustrates some examples from the literature. When we look at comparative mortality rates, comparing these outcomes between residents, IDPs, and refugees in complex humanitarian emergencies, as shown in this meta-analysis looking at death rate ratios from 1998 to 2012, the worst outcome is seen in IDPs. Similarly, on the next slide, you can see the effect size means of mental disorder outcomes associated with displacement status, with non-overlapping and significantly worse outcomes for IDPs versus refugee populations. Whilst this appears to be the general pattern, it is vital to consider the diversity of ID populations globally and the variety of conflict-affected contexts in which they live, including camp versus non-camp settings, vulnerable life points, duration, and single versus multiple displacements. Moreover, the research has mostly focused on IDP camps, although less than 1% of IDPs live in managed camps, while only another 11% live in self-settled camps, mainly in sub-Saharan Africa. ID populations are therefore, in different countries, highly heterogeneous, and this has important implications for the health challenges they face, health-related outcomes, and long-term disease management strategies. The next slide shows our second key finding, which is that the situation of IDPs is characterized by multiple intersecting social determinants of poor health. In other words, there is a reason why health outcomes for IDPs tend to be worse than other conflict-affected populations. We need to understand the wider determinants of health rather than just specific outcomes. Understanding social structures and how they contribute to resilience or inform intervention development is critical. Major factors affecting IDP vulnerability include the fact that they are located almost exclusively in low and middle income countries, because that is where the armed conflict currently clusters. In these poorer countries, fewer health and social resources are available to start with, and they are further disrupted or destroyed by conflict. IDPs often tend to be from poorer zones within those countries where fighting also clusters. This means they are poorer at baseline and are exposed directly to mortality and other impacts of conflict. Within these zones, evidence suggests that those who become IDPs are often those least able to cope. IDPs face challenging conditions in displacement, whilst IDP camp conditions often present specific health risks. Where camps are well run, there is evidence that health outcomes improve considerably. Unlike those who do not displace, IDPs experience vulnerabilities due to loss of access to their property and lack of support structures left behind. There are frequently deficiencies in the IDP protection response and challenges in practical access to assistance, especially compared to the response to refugee flows. The factors that shape the situational vulnerability of IDPs are predominantly social rather than simply medical in nature. Indeed, this points to a clear link between IDP health and social protection more generally. Inadequate protection seems to be a key explanatory factor for poor IDP health outcomes. The next slide demonstrates the third key finding, which is that IDP health problems are made worse by obstacles in accessing essential health services. In principle, IDPs, as citizens of their country of origin, should have the same rights to healthcare as other citizens, unlike refugees, for example. However, in practice, alongside poverty, common obstacles to health service access, particular to IDPs, include politicization and stigmatization of issues by governments or particular sectors of society, distrust of state or other health providers with particular relevance in the context of the COVID-19 pandemic, vaccination access and strategies, the inevitable disruption of treatment for existing chronic conditions as a result of displacement or ongoing mobility, and the need to stay hidden as a self-protection strategy. Crucially, the interplay between displaced and populations, the host populations, need to be considered. Although host populations can sometimes absorb newcomers, conflict is not uncommon. Perception of the influx of outsiders, suspicion, stigma, disease transmission, particularly in COVID-19 and infectious disease contexts, all influence health identifying and health seeking behaviors. Finally, on the next slide, we allude to some of the additional information on the multiple issues that we identified for future research and policy work. And for more information, please refer to the report that we are publishing today. But I'd just like to highlight one thing that jumped out really for me was that there is very limited data on some disease burdens, particularly around non-communicable diseases like cardiometabolic, respiratory, neurological, neuropsychiatric, neglected tropical diseases, which are particularly relevant in IDPs, and specific subpopulations are underserved, whether pediatric, adolescent, maternal, or geriatric. Finally, moving on to the last slide, I would like to pass the ball over to Professor Bayard Roberts, who will highlight how health providers and policymakers can better enable IDP health outcomes. Thank you very much.
Thank you very much, Gina. And I'd also like to add my thanks to all of you for attending today. So we have 4 key policy and operational implications in the policy brief that we submitted to the high-level panel on internal displacement, and which are also elaborated on in the report we're launching today. So now I'm going to briefly go through these 4 key policy and operational implications. Susie, next slide, please. And if we could move on to the first point as well. Thank you. So the first key recommendation is to ensure equitable access to healthcare for IDPs through inclusion in essential health services. To be clear, we are not advocating for preferential access to care for IDPs compared to other conflict-affected or indeed non-conflict affected populations. Simply, fair and equitable access. This is currently not the case in many settings, and as a result, leads to worse health outcomes of IDPs when compared to other population groups, as was shown earlier in Gina's slides. We are therefore recommending stronger efforts to ensure greater access to healthcare for IDPs. For example, ensuring their specific inclusion in universal healthcare principles and related initiatives that are taking place and being implemented in many countries. We also need to recognise that this requires adapting models of care in some settings in order to address the specific health needs of IDPs in those settings, and including recognising where insecurity reduces the ability to deliver standard packages of care. In addition, an immediate recommendation is to ensure that IDPs are fully included in access to COVID-19 vaccine programmes. Susie, next point, please. The second point is to recognise the specific needs and vulnerabilities of IDPs in the governance response. So given that health risk factors for IDPs frequently differ from those in the general population, specific governance measures are required to address the particular health needs of IDPs in diverse contexts. For example, this may be dedicated humanitarian protection or development aid for IDPs. For example, it may be better inclusion of IDPs into wider discussions and initiatives on humanitarian relief and sustainable development. Importantly, this also requires more equitable health financing for IDPs, including engaging with global financing structures to mobilize resources. Equally importantly, this also requires improved means to independently track health financing for IDPs. Next point, please, Susie. So the third point is to strengthen IDP community participation. The coping strategies and resilience mechanisms used by IDPs and their positive health impacts were highlighted in the report. This includes how social support structures travel with internally displaced populations. It also includes recognizing the diversity of IDP experiences, profiles, capacity, and responses. Therefore, strengthening meaningful participation by IDPs and host communities in the design of health services is crucial. And related to this, understanding the nature of trust by IDPs and different authorities, whether they be government, UN agencies, NGOs, or indeed non-state actors in different contexts is really key, especially with regards to COVID-19. Final point, please. So this last point is a call to support essential data gathering and analysis on internal displacement and health. As we heard earlier, there are key information and research gaps on IDP health. And essential IDP health data must be more consistently collected by governments, humanitarian agencies, and research and academic institutes. This means better data on key health determinants, needs, and outcomes, importantly from different regions, non-camp populations, and should also be gender specific. It was also noted that these data should also address internal displacement driven by disasters and climate change, for which there is even less data currently. Crucially, not only should more essential public health data be collected, but it also needs to be shared and disseminated by humanitarian agencies and governments. At the moment, this is too often not the case. So thank you very much, and I will hand over to David now. Thank you.
Right, well, many thanks, Gina and Bayard. So there you've heard the findings that came out of this expert workshop earlier in the year, both in regards to the way that IDP health plays out, and also the implications that that has in terms of policy and operational responses. We're really lucky to have with us for the next section of this launch some fantastic speakers from just such 4 operational and policy institutions working on the one hand in protection and on the other in the health space. So I'm going to turn to each speaker in turn and ask if they'd like to say a little bit about the kinds of issues that have been raised in the policy brief from their perspective. Now, our first speaker is somebody who I'm really delighted to present. That is Cecilia Jimenez Damari. She is the UN Special Rapporteur on the human rights of IDPs. and she was in fact a participant at the earlier workshop and has been very much involved since then in following this issue up. Delighted to have you, Special Rapporteur. Over to you.
Thank you very much, David, for the introduction, and congratulations to all the organizers. My gratitude for the invitation, for my mandate to contribute to this important and, as somebody said, very timely project. The right to health, as we all know, is an essential part of the protection of internally displaced persons, and international human rights law and IHL, as condensed in the guiding principles on internal displacement, provide this right both within the context of the essentiality of non-discrimination and as a right by itself because they are IDPs. Indeed, the right to health in internal displacement settings is essential in many of the contexts of internal displacement. First of all, the prevention of arbitrary displacement, of course, a protection during displacement, whether it's in camp or out of camp, and not least as a condition, essential condition, for the durable solutions of internally displaced persons. And in the context of durable solutions, the right to health is embodied in the criteria of the right to an adequate standard of living. The two-day workshop convened for the report and the policy brief and for this network. And this report and policy brief are being presented today, and in which I have had the privilege of joining, has clearly set out the situation through its empirical findings from current research. But there is much more research that needs to be done. What is, however, also essential is in the use of those findings as the research implications on actual operations in the field and in the shaping of policy on the protection of IDPs really are very important to go forward on these issues. In much of my work as a UN Special Rapporteur on the human rights of IDPs, we observe that the health of IDPs is linked to both indirect and direct consequences of internal displacement itself. Much remains at the responsibility of the state, but as well humanitarian actors, including health actors. Our current situation of the pandemic emphasizes this point very well, where prevention of virus transmission is emphasized in much of the humanitarian operations, but also we need to have provisions of vaccines for IDPs on a non-discriminatory manner. I therefore congratulate the movers of this project and laud the inauguration of the HIDDEN, the Health and Internal Displacement Network, in the hope that it will contribute, well, not just hope, but I look forward to it contributing to IDP accessibility to quality right to health and on a sustainable manner. Much needs to be done in terms of ensuring the indivisibility of human rights in the protection of IDPs' rights, including, and certainly not at the expense of the right to health. And in all of this, I'm very happy that one of the key findings is ensuring participation of internally displaced persons, without which this will not succeed. Thank you very much, and congratulations once again.
Many thanks, Special Rapporteur, for some very on-the-point comments, drawing this connection really strongly between the protection of the rights of IDPs more generally and the kind of health impact that follows if that isn't adequately done. The participation, I know, of course, has been of special interest to your mandate, and we hope to take forward those discussions about participation in the health sphere in the future. So on that note, I'd like, though, to switch now from a very strong protection speaker to somebody who is really one of our key experts on the panel on health. And this is Rifat Hossain, who's speaking to us as part of the Health and Migration Programme of the World Health Organization, the part of the UN that is mandated to deal with health issues. Over to you, Dr. Hossain.
Thank you very much, Professor Cantor. First of all, I would like to thanks very much the organizers for this important event and workshop, and allowing us to bring WHO views and present our programs and priorities. So as you know, that WHO is the normative organization, has been the directing organization within the UN system on policies and programs on health. And health and migration has been in the WHO framework for a long time. Although our program is relatively new, it has been set as part of the WHO transformation, the global program on health and migration, and it is now in the cross-cutting programmatic and executive office in the office of the Deputy Director General. So over the last many years, WHO has developed and agreed policies and interventions to promote and secure health rights of refugees and migrants, including internally displaced and internal migrants. Notably, the 2019 WHO Global Action Plan promoting the health of refugees and migrants, which is known as the GAP. The GAP was based on earlier agreed WHO frameworks of priorities and guiding principles to promote the health of refugees and migrants, also known as the framework. And it was written in the context and aligned with the SDGs and WHO's own 13th General Program of Work, which is the WHO strategy as part of the WHO transformation. And within this transformation, our new Director General, well, he's not so new anymore, declared this triple billion targets, so 1 billion more people benefiting from universal health coverage, 1 billion more people protected from health emergencies, and 1 billion more people enjoying better health and well-being. Both the GAP and the framework were developed in close collaboration with the international communities such as the IOM, UNHCR, and consistent with the Global Compact on Refugees, Global Compact on Safe, Orderly, and Regular Migration. Many of you know, or maybe all of you know, that the GAP has 6 priority areas of action, and one of which, the priority area 5, is to strengthen health monitoring and health information systems. But it is also key to the other priority areas, that is to promote the health of refugees and migrants, including IDPs, promote continuity and quality of essential health care, advocating the mainstream of refugee and migrant health into global, regional, and country agendas, enhance capacity to tackle social determinants of health, or to support measures to improve evidence-based health communication and to counter misconceptions about migrant and refugee health, which is probably very pertinent to the topic of the discussion today. To promote the implementation of these high-level frameworks, including the GAP at global, regional, and country levels, our program, the WHO Global Program on Health and Migration, identified 5 core functions, 2 of which are set norms and standards on health and migration, including co-development of guidance and tools, and promote a research agenda aimed at generating evidence-based information to support decision-making and global guidance for new tools and strategies on health and migration, and to monitor trends, strengthen health information system, develop accountability framework and indicators for progress monitoring and reporting on the implementation of the Global Action Plan and other international frameworks. So strengthening the evidence base is key to our, one of the key areas of our work. While some of the above frameworks and global agenda are supported by a well-defined monitoring and data systems, overall an indicator framework is not available, which would be needed to meet the objective 1 of the Global Compact on Migration, with its aspiration to collect and utilize, create and disaggregated data as a basis for evidence-based policies, and also objective 5 of the Global Action Plan. So one of the workshop focus is how our own institution works in IDP context. So I would very quickly say that we are strengthening our data works, that is support member states in developing indicator and data frameworks, conduct an evidence-based periodic assessments of health and migration And we are in particular embarking on the World Report on Health and Migration and Global Evidence Reviews on Health and Migration. Thank you so very much.
Excellent. Many thanks, Dr. Hossain. And I think what your talk brings out a little bit is this idea of strengthening the evidence base, which is so crucial. And this is one of the areas which I think really drove us to engage in this work with like-minded experts around the world, is this feeling that there is quite a bit of a body of evidence around refugees and migrants, but when one gets to internal displacement, the health literature is rather thinner or more fragmented. And so this idea of trying to promote more work in this area, not only on the research side, but the policy side as well, is certainly something we're very keen to continue in conversation with the WHO about. Thank you again. Our next high-level speaker, I'm delighted to invite William Chamali, who is the coordinator of the Global Protection Cluster, which is one of the main components of the international humanitarian system. I should also say that Mr. Chamali was also the founder of the joint IDP profiling service, which is in fact one of the main profiling and data gathering institutions globally on internal displacement. So it's with great pleasure I give the floor to you, Mr. Chamali.
Thank you very much, David. Can you hear me well? Great. Well, first, I would like to congratulate you on this issue-centered approach that you are taking. So before the substance on the shape of things, it's no secret that the way humanitarian coordination as set up today has served for over a decade and is ripe for an evolution to adapt to the challenges we're facing. And I firmly believe that alliances and coalitions and groups that come together with diverse backgrounds, mandates, and expertise, and try to attack complex issues like the one of today is how the next decade of a humanitarian action will look like. So what you're doing here today fits well in the trend, in the shape of it, and I highly encourage it. We are keen to engage and learn from, also to address other issues in a similar way. So congratulations for that and well done. Second, regarding the substance, over the last year, our roughly 1,000 members report that people we work with and for experience an alliance between the problems. The problems are reinforcing each other. Land degradation with a pandemic, violence, poverty, bad governance, lack of infrastructure are making it very difficult for families and individuals to cope. So we see a rise in some phenomena, and I would like to highlight a few of them. And everyone from a protection perspective will see that it rings a bell, but also everyone from a health perspective will see that it rings a bell. So in our operations, we see child marriage. Over 80% of the clusters report an increase in child marriage in the last year. Gender-based violence. Out of 30 operations, we have 27 reported as extreme and really severe situation. 70% of our operations report trafficking in people as a current risk that is going upwards. Almost 100% report psychological distress as a current risk, and the majority is in a severe situation for people we work with and for. People with disability and elderly are left behind by their communities and families because they're running out of options. And we see increase in sexual and social exclusion and stigmatization and discrimination, and more victims of mines that have exploded or unexploded ordinances as well. So now very little needs to be said on how each of these protection phenomena, in our view, have a very direct health dimension. So long story short, having good health services, accessible health services, does protect people. Having good protection programs increases access to health facilities that exist by those who are most in need. And importantly for us, having health personnel on the ground that have a protection eye helps identifying the protection iceberg that is under the health tip that shows up in a clinic on the front line. So now to conclude, and from a practitioner perspective, we really welcome studies like this. We welcome further investment in data that helps us understand how to address these issues in a smarter way. Data makes us smarter. And I would like to suggest 3 key areas that are especially important from a protection perspective to dig deeper. First, we need to step up engagement with communities for international programs. We believe this presence and engagement with communities, both for protection programs and mobile clinics, is very important. You can't identify the problem and definitely not resolve them unless there is a trust and this ongoing engagement with community. So engagement with community improves health performance, if it exists, and improves protection. That's 1. 2, we must continue ensuring that where possible, services are delivered through local actors. That's the most sustainable way we see. And this is a way where there is best trust in order to address the issues. So having a strong local dimension to the types of services we deliver is key strategy forward. And I read it in the subtext of much of your paragraphs in the research. And finally, we need to keep raising awareness and engagement with military personnel, with armed groups on their behavior during conflict. We must ensure that health providers are not a target. And that's an ongoing process that requires all our communities to come together. So in brief, thank you. Good luck. Count on us and onward and upwards for this very exciting alliance and work.
Well, fantastic. Many thanks, Mr. Jamali. And I think a very powerful presentation, this idea that the problems are inextricably intertwined, but then so are the solutions, and alliances is where we need to move towards. And similarly, your last 3 points, I think there's a great dovetailing of the analyses on your side as an operational agency and on some of the things that we and our academic colleagues were able to pull out of the research that's been done. For our final speaker, I would really like to give a very warm introduction to Dr. Kieran Putra, who is the Deputy Medical Director of Médecins Sans Frontières, who, I'm sure everybody on the call will know, is one of the leading medical institutions working particularly in context of humanitarian crisis. Kieran, as a colleague, a fellow researcher, it's a very great privilege to have you speak here. Over to you.
Thank you very much, David, and thank you everyone for the invitation to join you today. I was very encouraged by this work, which resonated with MSF's experience of working with IDPs over recent years, and particularly the consciousness of the diversity of conditions and circumstances in which displaced people are living, and the high mortality and unmet mental health needs in these groups, relative even to refugees. So I wanted to draw attention to 3 points made in the report, and that have also been made by some of the other speakers today, and look at their implications for health service delivery. So the first is the importance of social context and networks. The second is the need at times for differentiated care and services adapted to the needs of IDPs. And the third is the importance of dignity and participation in service delivery decisions. So for the first point about social networks, our sense is that social networks, and I'm not talking about Facebook, I mean traditional social networks, sources of income and sense of safety are primordial concerns for most IDPs. And these are concerns that will usually precede accessing care. So care provision must be framed within the logic of the wider informal support networks that people find themselves in. And this is especially the case since formal support may continue to carry risks for displaced people in some contexts. So this needs to happen in a way that is also compatible with the often fragile employment opportunities that displaced people have. And I think we've seen numerous examples, particularly in Somalia, of this, where the ability to generate income becomes, of course, the first preoccupation, and that may without income, health service access may become a very secondary concern. So these informal support networks can also enable healthcare providers to reach people who cannot access health services at all because they are housebound or fearful of contact with authorities. Secondly, the report talks about recognizing the specific health needs of IDPs and the importance of this for achieving health equity. So whilst IDPs are citizens of that country and thus in theory are entitled to all services, as everyone here knows, in practice this is often not the case, as their presence may not be appreciated by authorities or populations, and health services may just lack the capacity to expand to meet their needs. And the report reminds us that those needs may relate to pre-displacement vulnerabilities, as well as things that have happened to people who have been displaced en route. So addressing the combination of multiple needs and barriers to access may require a different delivery model. For example, locating services in accessible locations or locations that are experienced as safe by displaced people. It may mean providing care on the move, and it can often mean integrating care for multiple morbidities, including mental health, including reproductive health. As William pointed out, very often there are protection issues hidden under the surface, whereas the first reason for someone seeking care may be for a very medical need, for medication. So I think that after the emergency phase, of course, attention should focus on expanding capacity in normal health structures and ensuring these are safe and welcoming for IDPs and the host population. Finally, this work highlights the importance of community participation in service design and delivery. And for us, this is critical to the concept of dignity, because people on the move have often experienced great loss, be it of their possessions, livelihood, family members, health, their social networks. And health service provision can contribute to restoring dignity, but all too often it can dehumanize further. And we've seen examples where people are required to travel into camps to access certain health services, even though they themselves are living outside camps. So whilst at times distance from state authority structures may be helpful in establishing a sense of safety, in other circumstances, ensuring IDPs can access normal health services in town centres or wherever may be far more empowering. And including displaced people in decisions about themselves through participation in service design and delivery can make a contribution to restoring that dignity. So I think just to finish off, I would say that I'm looking very much at the operational implications for health service delivery. I feel we should put priority on contextualizing health service delivery within the broader frame of people's social needs, such as income and social networks. I think that differentiated care for IDPs may be very important, especially in the emergency phase. And then after that, looking at inclusion into routine health services. And finally, enabling displaced people to participate in service design and delivery. And with that, I wish you all the best and good luck with this fantastic initiative. Thank you.
Well, many thanks indeed, Dr. Kieran Putra. I mean, looking through the notes I was taking as you were speaking on such a wide range of issues, it's very clear that the approach of MSF in its operations does seem to resonate with a number of the findings and recommendations that are being made here. And I really liked your call for the close attention to context, because it may very well be that the evidence shows that in general IDPs tend to have worse health outcomes across a number of areas than certain other populations. But the way into that, I think, is very context specific. I mean, we've had a number of questions I can see in the chat about, what about where you're dealing with IDPs who aren't living under the authority of directly of a state, but where they're in a conflict context, there are non-state actors around, etc. So I think this call to appreciate these issues in operational terms around the context that exists there is a really, really important one. Thank you ever so much for your intervention. We move now very briefly, and I'm very pleased to see that a number of questions have indeed been raised in the chat. And I'm going to just ask each of our speakers to take something between a minute and 2 minutes to very quickly respond to perhaps one of the questions that they've seen raised there. So in the first place, I would like to start with the Special Rapporteur on Human Rights of IDPs, Cecilia Jimenez. Would you like to pick a question?
Yes, thank you very much, David. There are a lot of questions, but I would like to concentrate on state responsibility, which is something that is essential if the governance aspect will be addressed with regard to delivery of the right to health, accessibility of IDPs to the right to health, etc. And indeed, this is quite one of the biggest problems, because the right to health, it's a right, and this is something that has to be provided and facilitated by the state. And we all know that in internal displacement context, there is state responsibility, which is the basis for governance, and sovereignty is one of the principles. That sovereignty as responsibility is definitely one of the principles that emphasize that. But there are, of course, problems, and one of the very first problems that we see in many countries is the acknowledgement of the state that these IDPs are their citizens. These IDPs do have the right not to be discriminated against, and certainly that the government itself should not be doing the displacement itself. This is all within the obligation to prevent arbitrary displacement. So I know time is very short, but I would just like to emphasize that much of the work with regard to the policy implications in the right to health is really making the state, through its government at different levels, accountable for either commission or omission, because the right to health has certain implications on the situation of IDPs in general, but it is also very essential if one will be pushing for social cohesion in any context where we find internal displacement as a dominating factor. Thank you so much.
Many thanks, Special Rapporteur. So there you have it on the right to health and the relationship to states' responsibility. Dr. Hossain, would you like to pick a question and respond, please? Okay, in that case, can I pass over yes, Mr. Hossain, Dr. Hossain, go ahead.
Sorry, Professor Kantoria, I was not able to find my unmute button. There are a few issues that I saw on the chat and question box that cuts across various issues. Special Rapporteur just talked about the right to health. So just a couple of things. We are actually finalizing an evidence review on national policy adaptations to COVID-19 vis-a-vis the health of refugees and migrants. So every time, David, every time I'm talking about refugees and migrants, IDPs are very much included. We are not excluding them, and we are trying to highlight them as much as possible. As you said, the data is scarce and often scattered and so forth. So so basically this report is going to highlight that how the national governments across the world responded. So it may actually address some of the points that Special Rapporteur raised. William talked about the data makes us smart. I would say it doesn't only make us smart, it is an essential feature for effective policy formulations or targeted interventions, as Kieran said, is needed for service delivery and so forth and so on. So we must invest in this thing. There are lots of data, but if you actually scratch beneath the surface, you'll find that these are very anecdotal evidence. Systematic evidence across the world, systematic evidence even at the national level is quite scarce. So this is one of the priority areas of our program and WHO to invest in that so that we can make effective policies, and these policies can be translated into targeted interventions and improving the lives of IDPs. Thank you.
Great, many thanks. And interesting to bring up the point about data. I mean, I think you're absolutely right. You know, there are pieces of data around. The review that we were doing looked at peer review published data. In other words, data that had been put through a robust process of peer review, and therefore, you know, some weight could be placed on it. And I think that when we talk about data of that kind of quality, then we do find more difficulties there. Very encouraging, though, to hear that WHO is including, or is moving to include IDPs within its policy and programs. So, Mr. Chamali, would you like to take a pick of one of the many questions that now appears in the chat box and have a stab at giving your response?
Thank you very much, David, and thanks to everyone for the great questions that are in the chat box. I will take on the COVID question. COVID situation that goes beyond health had two types of effect on internal displaced population. One that is the obvious, it's the direct health issue, implications of people catching COVID and not having access to health services to deal with it. That's one important element. It's important to say that IDPs had higher rate of catching COVID. It's also important to be careful with that, because with that sentence that I just said, there's a whole stigmatization syndrome that we have seen in several operations, such as Colombia that comes to mind, or Burkina Faso, where internally displaced people were blamed for spreading COVID-19. So that's an important dimension to take into consideration, and that shows this interlinkages between health dimension and overall protection and well-being of people dimension. The second type of issues is indirect. This COVID situation has created a lot of psychosocial burdens, a loss of livelihoods in several contexts where internally displaced relied on it. And with less options, IDPs have been cornered into what we call negative coping mechanisms, have opted for choices like what I mentioned before, higher rate of child marriage or children labor, or a situation of higher risks of mental health related issues or higher rate of trafficking. And these secondary effects of COVID have a direct health effect in their own capacity as well, where people who are victims or survivors of gender-based violence and trafficking and mental health and child labor, that creates health problems where the services are not there. So the complexity of COVID for IDPs, like any other community, but in a more aggravated way with less coping capacity, has this direct health impact and have this health tip that is built on these protection problems iceberg that comes under it. Thanks a lot.
It's a very stark image, the protection iceberg underneath. Many thanks, Mr. Chamali, for the comments. Dr. Kieran Putra, MSF, and you have the final word.
Yeah, in some ways I would have liked to pick up on the exploitation question from Sam, but maybe that's for another time, because it seems there's a lot of questions about the issue of community engagement. And I just, from my side, I just want to say that, well, two things. I think that it's important. Sometimes the way it's described here, it seems like community engagement is presented as something that gets done and then results get shared. And I think we need to not see it as a noun, but more as an adjective or something that, you know, describes how we work, because we are, I can think of a number of examples of how we've worked with populations over years now, in service delivery design, in also organization of services where services are set up. And also in the example of COVID, I mean, we've done that in several settings, right at the very start of the intervention, a very in-depth process of working with communities to define what are the priorities in that setting, where should services be delivered, and including in displaced communities. So I just think that community engagement, it depends what you're doing it for. I agree that it's probably much more complicated when you are trying to carry out some type of process of consultation or a participative process to design policy. But where, from the perspective of MSF, where we are engaged with communities in service design delivery decisions, I think that we feel that this works relatively well. In fact, I don't think we can imagine now going back to doing it differently.
Well, many thanks indeed, Dr. Kieran Putra. And in fact, quite a number of the pieces of evidence around this issue were, I think, published by those who've been working with or alongside MSF. So some really valuable contributions to the research body there as well. Thank you again also for picking up on comments, a number of which were on this issue in the chat box. I'd just like to ask Professor Roberts, Dr. Swartz, any final words before I close? Wyatt?
Yeah, hi, thanks, David. I want to sort of highlight the point that's been made really on the sort of need for intersectoral approaches, and particularly this overlap between health and protection. I think this network provides a real opportunity to strengthen that sort of intersectoral approach to address some of the critical issues that have been highlighted today. So I think there's a lot of opportunity to build on that. And thanks a lot for all the comments in the chat box. I think we're sort of really keen to sort of learn more and develop this a lot further. Thank you.
Yes, and if I might just add to that and also second what you've said, Bayard, I think that the evidence shows that there is a lot that is hidden. Hence, I think the need to create a network to identify the hidden or unknown aspects of this, but to enhance or increase the data that is gathered, increase the research, and again, not just in critical, vitally relevant issues such as the current COVID crisis, but in issues beyond that. I think there were some questions about the main gaps, and we identified a multitude of gaps. It's not just in terms of the gaps in terms of healthcare and healthcare issues, but as we've also said, the gaps relating to the community's perception of health and disease and the ability to interact or engage in health-seeking behaviors. That is also so critical. Concepts around trust, identification, willingness to engage are also critical to ensure that we can actually move forward in this space. So I think that gives a very good segue back to Professor Cantor, who is just going to introduce our so-called hidden network, Health in Internal Displacement. And I think is also quite an important concept because as somebody raised, the indivisibility or invisibility of human rights is also at play here. And that largely remains hidden when we look at some aspects of health issues in this space. Again, not just exclusive to internally displaced populations, migrants and refugees as well. But of course, we're coming to this particularly within the context of internal displacement and all the issues relating to government, state, and other actors' responsibilities in that space. Thank you very much.
Well, many thanks indeed, Dr. Swartz, Professor Roberts, all of the panelists for your insightful comments, and of course to all of those who were brave enough to pose questions in the chat box. Thanks very much for your interventions. In closing, to launch the new Health in Internal Displacement Network, HIDDEN, I'd like to use the final couple of minutes to explain what we'll be doing and how you can get involved. The network itself was set up by an enthusiastic group of expert participants in our joint workshop earlier this year. And as you can see from the screen, the members of the core group represent a wide range of countries, specialities, and backgrounds, mostly researchers, but also some policy actors. This diversity of expertise helps the network in reaching its broader objectives, namely to highlight current research through webinars, discussions, workshops, to identify knowledge gaps, publish work, push forward ongoing research in this underserved field, and to promote further positive action to address unmet health needs in situations of internal displacement. Now, as a first step towards building a more robust global research community on IDP health, we'll follow today's event with an initial series of 3 free public webinars over the next couple of months. Oriented around topical themes, in these webinars, network members will be sharing key findings from their in-depth research on IDP health in different country contexts, with significant space left for discussion, debate, and follow-up. As you can see on the screen, the topics are really great, so please do register, come along. Registration will be open on our website from the end of this month. Other planned activities for the network include a series of research publications and eventually new projects, as well as activities around promoting ongoing engagement with policy and operational platforms relevant to IDP health and protection. All of this, though, is to say that we welcome new members. Joining the network, which is free, offers a variety of opportunities to develop contacts, collaborations, knowledge, and projects with a range of really leading researchers globally. Even if you've not previously worked on IDP health, so long as you've got the research, policy, or operational background to contribute to research and policy engagement in this area, then do consider coming along. Of course, if you already work in IDP health, then you're very welcome too. If you would like to get involved, please respond to the email from us that you'll receive later today, which will also share with you the documents, the policy brief, and the workshop report. Lastly, on behalf of my co-conveners, Dr. Swartz and Professor Roberts, I'd like to say a special thanks to Susie Reardon-Smith at the University of London, and to Fern Brooks, Holly Rogers, and Abigail Bloy at the Academy of Medical Science for all their assistance in convening both the February workshop and the launch today. And I'd also like to thank founding Health and Internal Displacement Network members, Winifred Akezi, John Bosco Chikwoji, and Alistair Aja for recording expert talking head videos, which you'll also find shortly on the website. Finally, many thanks to all of you who tuned in today for participating in this discussion on enabling health solutions for IDPs. We hope it spurred your curiosity for further engaging with the challenges of IDP health. The significant needs, health-related and others, of these underserved populations urgently require to be better addressed on the global stage, both in the current COVID context and beyond. Good day.